Hello and welcome to the Under Pressure podcast. I'm your host, Dr. Jonathan Sacchi, and I'm very proud to be your host. Before introducing today's guest, it's important to specify that this podcast was supported by Myo1, a Canadian medical device manufacturer. So please refer to the show notes for further information. And you can be in touch with us at underpressure@nextsense.com. That's underpressure@nxtsens.com to ask any questions that we'll endeavor to answer them. And if you've got any suggestions, I'll repeat that again at the end. So today, I'm delighted to welcome a distinguished expert in orthopedic surgery, digital health, and sports medicine. Professor Mohamed Imam, or Mo as he goes by, is a consultant trauma, hand, wrist, and upper limb surgeon at Rowley Bristow Orthopaedic Unit, Ashford and St. Peter's Hospital at Chertsey in the United Kingdom, as well as a professor and executive medical director at the Smart Health Centre at the University of East London. I only met Mo recently when I went to give a talk on some perspectives on trauma surgery. And he's just one of those chaps who's instantly likable. And, I just frankly wanted to sit and chew the fat and talk about many, many different things. But he's a very, very smart cookie with a PhD in orthopedic surgery, a diploma in sports medicine from the FIFA Medical Academy. That's the body that oversees professional football, or soccer, as our American friends would call it. And he's an executive leadership diploma from the University of Oxford, that little known university. He's not only an accomplished surgeon, but he's also a pioneer in applying artificial intelligence to orthopedics. He's published extensively on topics ranging from upper limb trauma and sports injuries to AI-driven medical solutions, and he's authored books on orthobiologics and digital health. So you can see he's a very, very accomplished gentleman. And today we're going to be discussing his pioneering work in digital health, his experience with sports medicine, and how various technologies can improve clinical care. So without further ado, let's welcome to the Under Pressure podcast, Professor Mohamed Imam. Mo, how are you?
Hello, how are you, Jonathan? And thank you for the lovely introduction. It's great to be here with you. And mutually, I've enjoyed our meeting before, and I'm looking forward for more of these.
We were talking just before we got going about, how one of the joys of medicine is solving problems, right? And dealing with different perspectives that we always have and coming to the best solution for our patients. And as I said, we met over a discussion about a new technology that we'll address in a while. But what struck me was how interested and focused you were in discussing the technology. My sign off to any podcast I always do is to encourage people to stay curious. And clearly, you're an intellectually curious chap. Tell us about that. Tell us about your motivation and your makeup.
I firmly believe curiosity is the foundation of innovation, whether in AI, surgery, clinical assessment of patients, or sports medicine. I've always sought to push boundaries and explore emerging technologies while maintaining patients' safety because there should be a balance there. And my exposure to international training, working in different healthcare systems in Northern America, Europe, and the Middle East, and my huge involvement in research have all fueled this curiosity. The key is to stay adaptable and embrace the rapid pace of change in medicine. Historically, we used to say that medicine change every decade, but now I think actually it doesn't take that long because we can see with the advances of AI in the last few years that changes are actually enormous and takes little time to evolve into a newer era, which reflects positively and negatively on ourselves as clinicians and most importantly on our patients.
Yeah. I recall being told that when you graduate 5 years after, 50% of what you've been told will be proven to be wrong. The issue is working out which 50%. And if we had certainty about everything, well, don't they say about us surgeons that we're always certain, occasionally right? That having that humility to question, that curiosity to inspire, and like you, I share a love of innovation and seeing how it can improve patient care. So you mentioned working internationally. You've done fellowships at the Mayo Clinic, Harvard, and Stanford. Again, three pretty prestigious institutions in America. How have those experiences shaped your approach to orthopedic surgery and patient care? And what would you say that we in Britain do well compared to the United States? And what could we do better?
So training in having traveling fellowships in the US provided exposure to cutting edge surgical innovations, interdisciplinary research, and an entrepreneurial approach to medicine. While in the UK we excel in evidence based practice, patient safety, and structured NHS training, we still could improve in adopting emerging technologies faster and in fostering a more research integrated approach to all levels of training. We published a paper recently uh, about, basically, I firmly believe that transforming the NHS through AI driven solutions will be the new era and the only hope maybe for the NHS. And in a previous paper, we classified the major challenges we face here as the 6 C's, and these are communication, collaboration, compliance, constraints, culture, and caseload. And these issues, coupled with a backlog of incomplete projects, have hampered ineffective management and strategic planning. And actually, maybe I'm biased, but addressing these 6 C's require not just technical fixes, but adaptive, system wide changes that promote collaboration and flexibility from all stakeholders in the NHS.
Yeah. Well, you mentioned, I mean, I love that. I've never come across that before. I really like it. And I love the one about culture. And I think,
I proposed that as the 6 C's. It was me who
oh,
wrote, yeah.
there you go. I mean, coming back, I spent half my life in the United States, trained here, went to America, and came back. And I have to say, the one thing that I always thought we did well here, and that seems to have been lost to some degree, is the culture, a culture of caring, a culture of supporting the patients. And I appreciate that people are under a lot of pressure, but my goodness, Osler said it perfectly. A good doctor is able, available, and affable, being nice. I think we could do a better job at that. And but then again, sometimes in America that can be a challenge as well. Put
No, I
that
think
as
actually I cannot agree more. And I think actually being a patient recently, I think actually, and like also as a surgeon, I tend to take a lot of reviews from my patients. And after doing very complex revision surgical reconstructions, which I think, involved a lot of technical skills, and my patients' feedback and their top point is that I've listened to them, they felt that I care about them, and that actually is priceless for patients. And that's actually why, even with AI and all the advances we have, we still have to have compassion at the forefront of everything we do, and the personal touch is it has a huge impact here.
well said. I mean, the application of technology can sometimes take away from the laying on of hands, being next to the patient and making them feel better when they're frightened and in pain. And we're going to come on to some aspects of that. So I want to pick up on something. You've specialized in applying artificial intelligence, AI, and machine learning to orthopedics, particularly in predictive modeling for sports injuries. Can you expand on that and how you see it being more broadly applied in orthopedic care?
So it is an excellent question. And personally, AI allows, what is AI first? AI allows us to analyze vast data sets,
Absolutely.
recognizing patterns that predict injury risks. We can use machine learning models to assess biomechanical stressors in athletes and develop personalized training regimens to prevent injuries. We can definitely enable personalized treatments. We can optimize rehabilitation by tracking recovery trajectories and suggest adjustments based on real time data. So AI is a very a smarter version of us that will enable us to do things we couldn't do before. And we have published and we're still publishing and looking at different tools that will enable our athletes to do more, and actually not even professional and non-professionals can uh, do better by avoiding injuries and enjoy doing the sports they are designed and destined to do.
Yeah. And more broadly across orthopedics, I mean, you talk about analyzing huge data sets, obviously for research and
I
bringing.
have a good analogy for AI. It's like, actually, it is like a human being. So, for millions of years, our main achievements as humans has been human intelligence, and that enabled us to design tools, and these tools enabled us to dominate the world. And it is the first time in history we delegate this intelligence to someone else, another species. And actually, AI has the same senses as we have, except for the sensation of touch, maybe, although this is being developed now. So in orthopedics, there is the computer vision, which is the eye, which is looking at patients. You can tell this patient is doing well and this patient is not doing well, but that's still based on your own intuition as a clinician. But if you have millions of data points, that will be more accurate. And we are actually designing a platform for prediction of progression of arthritis and other medical issues. Pattern recognition, so we can see that if based on historical data, AI can recognize patterns and can predict outcomes. So in orthopedics, if someone is a smoker and he or she is diabetic with high BMI, we can tell them you have an increased risk of having infection if we go for a total hip or a total knee replacement. There is also the sensation of the sensation of touch, which is even being developed, which is action potential and things. How can AI, can robots actually assist in doing things? Yes, that's why we're using a lot of robotics. I personally would use augmented reality shoulder replacements in every patient I'm doing. And there is huge potential of other aspects we're doing, and there is more and more coming out as we progress. And personally, I think I've added 10 IQ points just by being able to use AI properly in my practice, because you can also include AI in dictations, in ambient voice recognition, listening to consultation with patients, chatbots that can help you and advise you in surgery, in your clinic consultation. If you're a junior trainee seeing a patient with complex problem, there is unlimited usage for AI in our practice nowadays.
Yeah, wonderful. That's a fabulous summary. I've been very interested in robotics for many years and have often thought, and in fact, the very first robot that inspired me was an orthopedic device, the RoboDoc. What was the guy's name? Paul, I think it was.
Okay.
And it was to do precise placement of femoral prosthesis. Yeah, the future is bright. Well, let's stay on this a little bit. Digital health and AI are playing an increasing role in diagnostics and treatment planning. We talked about compartment syndrome when we met. Do you think AI could potentially help identify cases earlier? And other places that it might be germane, other clinical scenarios? You've done a lovely job talking about its deployment, but compartment syndrome and other clinical scenarios.
Absolutely. So, compartment syndrome, as you know, is a life changing event. AI can integrate real time sensor data, patient history, and imaging, and other measurement tools that we have nowadays to flag early signs of compartment syndrome. We know that if we can, non-operative and non-interventional methods can work significantly well at early stages of compartment syndrome. So AI can have broader applications in trauma care when can enhance triage, automate diagnostic, optimize surgical planning through the predictive analytics we've mentioned briefly. But actually, in compartment syndrome, I think actually collecting data, analyzing this data, possibly can enable us to predict patients who are more likely to get compartment syndrome. We can integrate real time data as well into our current data so that we can actually improve the outcomes of our patients with these problems. And especially, I think AI and automation is most useful in critical scenarios where you cannot have the highest expertise there at at all time points, and possibly that is where AI most powerful point in care, in clinical care. And compartment syndrome is one of these aspects that I believe can benefit a lot from the use of artificial intelligence.
Yeah, absolutely. So, can you share notable case studies where AI has come in to support the management of that scenario? By the way, I love your idea of using augmented reality to do shoulders. I fly aeroplanes, and we use all sorts of augmented reality to help us, land on the runway instead of the taxiway or an adjacent road, which is awfully embarrassing. So, yeah, any uh, case studies that you can come across, or we know that any new technology that you have to cross the chasm. Have you encountered resistance from some of your more, shall we say, staid companion colleagues about adopting AI?
Of course, there is always resistance to new technology, like even and history. If we read history, we can predict the future. That's for sure. And this is often due to unfamiliarity or concerns over autonomy, or people being afraid of change. But it is happening whether clinicians like or not nowadays. And because it's like the internet. You can resist the internet as much as you can in the 90s, but it doesn't mean that you are now you will be now a full user of the internet, whether you accept it or not. However, when we actually, there is some evidence saying that AI improve outcomes, and as in, with the more the evidence we have, the more the improved outcomes we have, acceptance will follow. And one
Yeah,
example is actually using one actually example we have done, and we had an ethicos grant, and we made a predictive analytic model for patients who will progress into surgery. And we found that using an AI powered decision support increase the risk, increase the outcome, and it actually has enhanced risk assessment accuracy, where we're developing one for infections now, post-operative infections. And obviously, as a surgeon yourself, we know that an early intervention can significantly improve patient outcomes. And more we published a paper in the Lancet about the uses of actually intersection between human intuition and AI in prediction of bone and joint infections. And there is more evidence as we talk being published on daily basis.
interesting. So, I want to come on to another possible application. So, I'm fascinated. I've never been a great football player. I love football, and for my sins, I support Tottenham Hotspur.
I'm
Uh,
very sorry to hear so.
I know. Listen, we've all got our burdens in
Yeah,
life.
no one
Uh,
is perfect.
no one is perfect, exactly. So, for the benefit of our overseas listeners, it's a London football team, soccer team. They have had a huge number of injuries this season, mostly serious hamstring tears, probably due to their style of play with sudden and multiple sprints. I was seeing some data that they actually have the second highest offside traps in Europe after Barcelona, and the third was way behind them. The highest number of multiple sprints, the highest distances covered, and many, many other parameters. Tell us about some of the significant advances in sports injury avoidance and treatment. And I don't know who your team is, Mo. Who is your team?
Arsenal.
Of course it is. Of course it is. You're otherwise such a love. So again, for the benefit of our listeners, that's like the ultimate rivalry in British soccer. Um, Maybe you can come with me to a game, and I can show you the benefit of watching a
No,
game
but
live.
actually, I've been to Spurs Stadium. It's a lovely stadium.
Yeah, it's a lovely stadium. It
Yeah.
is. I just wish the football matched it. Um, but tell us about some advances in sports injury avoidance and treatment that you've seen, and what's coming down the pike in sports medicine.
There is huge amount of work. So, I'm a professor in East London, and
Mhm.
we have strong links with West Ham United as a university, which is for our listeners, it is another London team. No, and there is a bit of rivalry between the three clubs anyway. But actually, in sports specifically, because let's actually, what happens there? High intensity sports put extreme loads on muscles, leading to recurrent injuries. And with the level of activities we're talking about, this risk is even higher. So AI is helping by tailoring rehab protocols and predicting recovery timelines. Wearable devices, which you can see all professional footballers are having now, and there are more coming out, like the vests, the wearable devices, all track muscle fatigue, biomechanics, injury risk factors to optimize training and prevent injuries. And there is huge amount of work is being done there, even at younger stage now in our careers. You can even pick the sports that fits you the most. So if you think about the, like, if you look at someone like Phelps, the biggest Olympian of all times, having a large torso, looking at data variance at different time points, enables him to be the greatest swimmer of all times. But actually, that wouldn't, if he picked up running, he would have no career in that, because as a runner you need longer legs and shorter torsos. So actually, also AI can enable us to pick which sports to do, which no, not only genetically but also different aspects included. And most importantly, if you are a shorter player like Lionel Messi and you're a footballer, and no, you can be you it's actually doesn't make sense to be a center back or a striker, but you possibly, if you have the talent, that makes you more talent in controlling the ball, and certain positions can fit you. And also using this data and analyzing it, increase the balance of probabilities, the chances of selecting the right players in the right positions. And obviously we can predict injuries easily now. And one of my registrars actually were doing a big study on prediction of football injuries with partnership with University of Bath, and many databases available online. And also we're in contact with FIFA now, and we think we can, by training specific models accurately, we can predict specific injuries in players before they happen. So if you have a player that I think is prone to have an injury, and we stop them from playing for few days, that will prevent them from sustaining the injury and being away from football for few weeks, which is very valuable.
Yeah. Well, maybe I need to get you down to the stadium and have a look, because we at one point of our 25-man squad, 15 were on the injury
Oh
list.
yeah, it was
Yeah,
impressive.
we were playing. The manager said, "I've put the teenagers out, and when it's time for substitutes, it'll be the neonates." So
Yeah.
I want to change topic a little bit. Also, biologics, stem cell therapy, they're becoming more prevalent in orthopedics. I've tried to make sense of the literature, for instance, on PRP, platelet-rich plasma for knees, shoulders, and so on. What's the state of the art for stem cells and PRP for for people as ignorant about things as I am?
So actually, me and Professor Martin Snow from Birmingham, we wrote a book on orthobiologics as
Mhm.
an evolving uh, subspecialty in orthopedics in 2016, and still in 2025, the evidence is still evolving. PRP has mixed results in clinical trials. Possibly stem cells therapy shows promise in regenerating cartilage and soft tissue injuries. The cost and the commercial use is still debatable, but actually, the future lies in refining these treatments through patient specific evidence based applications. Because the issue is that it was commercialized very early, and I think actually there was few poor practices happening, which made the results debatable and confusing as well. Also, regulating bodies are crucial to maintain, a robust systems that would enable us to undertake these treatments safely. But it is or the term orthobiologic is simply using our own cells to regenerate our, because I think that's actually the future of medicine, is preventive and more bone preserving is the future of orthopedics specifically, because in the last 100 years any joint that is worn off we tend to replace it, but now we have to preserve it. And I think orthobiologic, with the help of AI as well, might enable us to achieve that.
Yeah, very, very much so. I was doing a review on PRP and its roles because my mum needed some treatment and I wanted to ascertain what would be good for her. And I came to the conclusion that there were the papers over here that said, "Yep, definitely works." The papers over here said, "Nope, don't work." And the papers in the middle said, "Who knows?" But
And
it's
I think actually, who knows is the right answer, especially as well if you look at the evidence. With and critically appraise the evidence. The problem is the term PRP. There are different cells into it. It's like, you cannot say a footballer is good,
yeah,
is a
yeah,
good person, because you have too many types of footballers. And so also the variables, there are a lot of variables in the injection, in what you inject, and as well as many variables in
yeah.
the pathology you treat with.
Yeah. And also, well, I mean, your PRP may be different to my PRP.
That's
So
another
it
thing.
most certainly is.
Yeah.
But yeah, fascinating. So do you see this evolving to the point that we could use these kind of technologies? Let's say you've had some muscle loss as a result of, for instance, a compartment syndrome. You've had some muscle ischemia, some muscle death. Can you see the point that we'll be able to treat the patients for such a misdiagnosis?
So, yes, is a short answer. Mesenchymal stem cells and growth factors could support muscle regeneration post compartment syndrome. Research is ongoing, but the potential is immense. More research is needed, which we possibly say in a lot of things, but actually, there is evidence coming. I think actually more. In the last 10 years, there is more research on stem cells and the potential use of stem cells and also biologics in general in regeneration. And especially when you have someone with muscle damage from compartment syndrome, I think they can be ideal candidates to try these options in them, because the options are not vastly available for these patients.
Yeah, sure. So that brings us nicely on to my next question. A little earlier, you mentioned the six C's. When I first got exposed again to compartment syndrome, I mean, I've seen patients with it during, trauma call, and obviously, as an abdominal surgeon, I was very interested in abdominal compartment syndrome, which is a nightmare to deal with: perforated diverticulitis, a gunshot injury, a crush injury, and taking these patients back to the operating theatre. It's a very difficult decision, and you end up nursing them on ICU for a long time as a laparostomy. It can be very, very problematic. So I'm fascinated by it. I'm fascinated by the diagnostic process. And when I went back and looked at it, holy cow, they're still using the P's that I learnt about back in the days where there were gas lights on the street in London. So you mentioned the C's, there were the P's. Talk to us about the biggest challenges in recognizing and managing this condition in the sort of trauma cases that you look after, Mo.
So the key challenge is early diagnosis, and this didn't change over the last decades since and dealing with patient with possibility of compartment syndrome is never an easy situation. Symptoms can be subtle, and delays lead to irreversible damage, and that's what I tell my trainees and fellows and residents. We never we I don't want to hear any of the six P's. For me, it's pain, 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 pain are the 6 P's, and
Yeah.
continuous pressure monitoring, AI, risk stratification, and clinical suspicion remains the best tools we have. And if we suspect compartment syndrome, we should act immediately on it. We're lucky in orthopedics, we don't have a lot of life threatening or limb threatening problems. So our own calls can be slightly quieter than yours when you're doing them, Jonathan. But
Yeah.
compartment syndrome would be one of the first indications that will make me drive to the hospital if I'm offsite, to make sure I see the patient and make sure we act immediately on it. And
Mm.
so the 6 P's, we still use them, but now the newer version of it is pain, 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 and pain out of proportion.
Yeah.
And usually we don't take it lightly.
Yeah, there are issues though, aren't there? Because you might be dealing with a patient who has got a head injury, is intubated, is inebriated, all those sort of issues. And having broken a bone, I swore that if the doctor came round and asked me one more time if I was in, how was my pain, I was fantasizing about causing him pain because all I knew was it damn well hurt,
Yes.
and I was in a lot of pain. And recently, some friends, their son suffered a tibial plateau, and they were asking me about regional anesthesia. Couldn't they block him so that he wouldn't feel pain? And I know that causes the concern. Well, how do you diagnose compartment syndrome? Maybe we can come on to that in a second. But first of all, talk to us a little about upper extremity compartment syndrome. It's not something I know a lot about. And can you walk us through the key differences, how it develops? I've also talked to people about the foot, and I'm still bemused as to how many compartments there are in the feet because it seems to change. I always thought anatomy was anatomy, but apparently not. So, talk to us about the upper limb, the key differences in its development, risks, treatment challenges, and any other factors you want to tell us about.
So the upper limb is more susceptible to nerve damage when you have compartment syndrome, but luckily it's not as common to happen in the upper limb compared to the lower limb. And the nerve damage is actually due to its unique vascular anatomy, while the lower limb sees high pressure thresholds. Both require rapid intervention, as you know, but possibly upper limb cases often present later and might require heightened vigilance. And in upper limbs, there are many compartments, especially including the hand. And also, it is always a very challenging problem to differentiate between life threatening and limb threatening infections versus compartment syndrome. But usually early intervention is the best modality to sort any, or actually to help improve the outcomes of whatever we do for our patients. And so it is in upper limb, it is always time critical to diagnose, because in lower limbs diagnosis might be easier, and with continuous monitoring things can be easier as well to identify. So it is still as challenging in both, but these are the differences I can think of
Sure,
now.
sure. Um, uh, a brief comment though about taking these patients to the operating room, the operating theatre. Fasciotomy is not, and again, I did them during my training. It's not exactly a minimalist operation. It's a darn big scar, and it's not an operation without, we were always taught there's no such thing as minor surgery, there's just minor surgeons. You operate on a patient, there are risks, right? There are risks, there's morbidity, and it's bad enough having a complication, but when that complication is after an operation that the patient didn't actually need because they didn't have compartment syndrome, that's always harder to stomach. Certainly, it was for me. What are your thoughts about unnecessary fasciotomies?
I cannot agree more to what you've just said. And, as a trainee and then as a consultant for so many years now, I can remember the number of patients where we did fasciotomies too, while, was it 100% needed or not? It's history. You never know. And actually, seeing them with the risk of infection and muscles protruding through scars and seeing plastics losing, and actually to in order for these patients, as the majority of them are fit patients who might have had a traumatic event. And it is definitely the other side from minimal invasive surgery, because part of the principles of surgery is to release all compartments, and that actually involves the biggest scar you can do on this compartment. And that's why actually prediction, or only doing it when needed, because we have also to understand that we're comparing someone who will take longer time to recover to someone who might lose a limb. So it's actually, it can be a life-saving procedure if done in the right patients. But as a procedure, I think actually there might be a general consensus it's taken more lightly than it what should be taken at, but definitely.
Actually, it inspired another question that I've not known the answer to, and you're, I think, the perfect guy to ask. So, whether you believe in intelligent design or evolution, the compartments are there for a reason. And I get shin splints. I presume I get chronic when I love going on long distance hikes. And, if I walk 20 miles, my legs are hurting me. And I often have to stop for a period of time and put my legs up in the air. Um, but if you do a fasciotomy, what do you do to the mechanical advantage of the muscle compartments? Do you change it?
Yeah, of course, and actually, even when it heals, after a long time, it heals by scarring, and actually, it's not anatomical. And we both were trained. All surgeons have been trained that restoring anatomy is our ultimate goal, because the anatomy we are designed in an anatomy, whether we understand why it is there or not, or we don't, but actually we have to restore the anatomy whenever we can. And obviously, compartment decompression, it really uh, enables patients to go back to 100% pre-injury performance levels. There is subtle changes, and the luckiest of patients will have uh, slightly reduced uh, function compared to themselves before the injury.
Yeah, yeah. I'd be interested to. I've been looking around to see if there are studies on, you know, capabilities, for instance, in footballers. And I believe, there've been a number of professional sportsmen who have suffered from this. So that's
And
fascinating.
actually, no,
So you've mentioned.
exertion
I'm sorry.
compartment
Go ahead.
sorry, exertion compartment syndrome is a problem that we see a lot in upper limbs and lower limbs, especially nowadays. We haven't evolved as much as we'd like to believe as humans, but our demands have evolved. What a 75 years old tend to do nowadays is unheard of for a 75 years old 50 years ago. And that actually
Sure.
makes us see more problems that we should evolve in how we manage them as well. And as
Yeah.
the issue we have with many of these is that the evidence is not strong enough, because not a lot of funds are invested in these patients. And also the other thing as well in in studies related to compartment syndrome, and the other problems is are time critical procedures. So actually it's very hard to undertake reliable uh, proms and prems for these patients while in the middle of the night in a major trauma center in anywhere on earth.
Yeah, fascinating. So, Mo, you've mentioned continuous compartmental pressure monitoring, which has been introduced as a tool to aid in the diagnosis of compartment syndrome. How would you envisage incorporating that into your practice, taking objective data available to you, whether you're in the hospital or not? Do you in I'd love to know understand your perspective of the patient pathway. Is it immediately after the fracture, arrival at the hospital, post-operatively, after a nailing, the ward? What are your thoughts?
This
What
is
triggered in your brain?
one of my favorite words is actually data. I love data myself, and I think actually continuous pressure monitoring is it is recommended in many studies, and it is being integrated into many trauma workflows nowadays. From the field to the ward, continuous monitoring can guide intervention timing, reduce unnecessary fasciotomies, as we've discussed over the last 10 minutes, while preventing missed cases. That's the ideal scenario we can have for these patients. And actually, doing that so that we only operate on the patients who will benefit the most from fasciotomies is good enough to invest into continuous monitoring. This doesn't replace clinical suspicion, but it is a great tool that will enable clinicians anywhere in order to, and makes us safe as well, because then you have the data that can support your decision if you're indecisive in what to do. And I think this is actually is being recommended and is being adopted in a lot of places nowadays as well.
Yeah. It reminds me. I told you I love I fly planes, and
I
we
know.
certainly have our digital and our analog fuel gauges. We have fuel consumption rates and estimated fuel at arrival, and all these different algorithms within the cockpit. But you could have all these things telling you one thing, and your brain is telling you something else. So your experience as a pilot, if the engine is making coughing sounds, that's probably not a good thing. And it reminds me, there was a famous cartoon by Larson where there's two guys sitting in the cockpit, and there's cloud in front, and there's a goat, and one pilot says to the other, "What's that mountain goat doing standing on a cloud?" Right. So the evidence of your eyes, incorporating data into the practice of medicine to improve our outcomes for our patients. I want to switch back to a different topic. Given all the roles that you fulfill, medical education, mentorship, what are the biggest challenges do you think facing a young man or woman going into orthopedic surgery today compared to when you entered the field?
Wow. We can do a whole new podcast just on this topic only nowadays, because I think actually that's a topic I'm fascinated about. Because I think now we are, I call this era nowadays is a tale of two generations, because we historically, surgeons were all about experience, the countless hours spent in the theater, the life saved and lost, the fasciotomy is done. It's all about experience, human intuition, and experience. And I remember a famous quote that every surgeon carries within himself a small cemetery, and actually that grows every year. But nowadays we have a lot of digital tools. It's actually, if you come to Ashford and St. Peter's, the main we for shoulder replacements, you will have an augmented reality shoulder replacements. That's our standard of care. Robotic hip and knee replacements. That's our standard of care. So as a senior, not me, but if we have a retiring consultant, they've watched their trainees with their tablets, automated workflows, digital tools. Young trainees want to move fast and speak in algorithms and trade in crypto. They trust the machines. Senior consultants trust their hands. Both are right, both are wrong, but the truth lies somewhere in between. Because we have to maintain the human touch, and the human touch should meet digital precision and artificial intelligence. Because simply, we writing papers and we're showing evidence that possibly augmented reality shoulder replacements are more accurate than a non-guided shoulder replacement, or there is some advantages of these. So actually, as a clinician, I'd like to offer the best outcome to my patients, but so that even if that involves adopting technology, we have to adopt technology. And as a young trainee, as for younger trainees now, balancing clinical workload with research and technology adoption, the field is evolving rapidly. Young surgeons are required to adapt to AI, digital health, and evolving surgical techniques. They should stay informed, collaborate with others, engage in research, enhance their artificial intelligence experience, because AI is not replacing anyone. It's surgeons who embrace it will lead to the future of orthopedics. And if you are a surgeon plus AI, you will replace a surgeon without AI, whether you like it or not.
Yeah, it reminds me of I couldn't agree more. It reminds me of the early days of laparoscopic surgery where there were some people who were railing about it. And it was like, no, this is an evolution. I mean, it's an evolution in surgery, and we have to evolve. What it is, like a shark, you just have to keep moving, right? You have to keep moving and keep growing. My last question is there anything I failed to ask you? And I think I could answer it myself and say yes, everything, because I could listen to you talk all day. You're very, very eloquent and very, very articulate, and you really know your field, and it's fascinating for me. But is there anything I failed to ask you that you wish I had? And if so, please leap in. And if not, can you provide the audience with a pithy sense of what the future holds for your specialty and maybe a pithy take home message?
No, I've actually enjoyed this podcast thoroughly, and it's always a pleasure to talk to you. And
Thank you.
it's entertaining as well. If we talk about the future definitely lies in personalized medicine, where AI, biomechanics, orthobiologics will converge to provide precision treatments for our patients. We see AI powered diagnostics nowadays is common tool used. Predictive analytics for injury prevention more are being produced, and regenerative therapists revolutionizing musculoskeletal care and optimizing patients' outcomes, because eventually, and actually there is in the digital health era, there is life expectancy is expected to increase significantly in humans as well, because imagine if you have your own wearable device and your own doctor predicting any changes in your blood pressure or heart rate or respiratory rate before it even happens. That will significantly predict the problem. Preventive medicine is the future of I actually don't like using the word future, because I think we are in the middle of the era now, and so that's really crucial in in the current developments we have in medicine nowadays.
Yeah, I think it would be right to say the future is now.
Yes.
And in the present, all that remains for me to say is Professor Mohamed Imam Mo, thank you for joining us today, for sharing everything, all the perspectives on the work you've done and the work you'll continue to do for patients. I think they're very, very lucky people to have such a smart and caring doctor looking after them. Thank you so much, Mo.
No, thank you, Jonathan, very much. Great to be here, and thank you for an insightful discussion. It's been a pleasure.
You're very welcome. And to our audience, thanks for taking the time out of your busy day to listen and demonstrate a desire to see the best care for your patients. And if you've enjoyed this conversation, and I struggle to understand how you could not have enjoyed this conversation, please share it with your colleagues, post on social media, write to us with comments or questions or suggestions for other podcasts. Again, we'll put this in the show notes. Under pressure at nextsense.com, under pressure at nxtsens.com. Thanks also to My One for supporting the podcast and disseminating it. And all that remains for me to do is to say, this is Jonathan Sakia. I'm your host. Please, everyone, stay safe, stay well. And as I said before, stay curious. Bye for now.